This week on the BackTable podcast.
My take on this is the whole purpose that you're doing surgery here is to avoid chemotherapy or radiation. So it doesn't make a whole lot of sense to do an RPLND and then because of a positive lymph node, you knew there was going to be a positive lymph node, to then go ahead and give adjuvant therapy and expose the patient to that potentially long-term toxic chemotherapy. So our sort of protocol has been to observe those patients with surveillance. Of course, there are some exceptions if somebody has an operation and they have very large, bulky lymph nodes, large number of lymph nodes, large in size, then potentially we could consider adjuvant, but for the vast majority of patients, we are observing with surveillance.
Hello, everyone. Welcome back to the BackTable podcast. This is Aditya Bagrodia as our host today, and I'm beyond excited to introduce our guests today, Rich Matulewicz and Nabil Adra from Sloan Kettering and Indiana University, and this Society of Urologic Oncology Testicular Cancer Tumor Board, which is being done and produced in conjunction with the SUO. Rich, Nabil really need no introduction in their own rights. Juggernauts in the germ cell tumor field, come from some of the most historic and storied places of germ cell tumor management, Memorial Sloan Kettering and Indiana University. Rich, Nabil, how are you all doing today?
Great. Really great to be here. Thank you so much for having us.
Very good. Thanks for having us, Aditya.
Well, I'm thrilled. This is our first SUO BackTable tumor board. It's a germ cell tumor, a disease that's near and dear to my heart. Thanks for being here. And with no further ado, let's jump on into it. So this is a patient from my clinic, healthy 23-year-old male who presents with a painless enlarging right testicular mass, no history of trauma, infection, no family history of testis cancer. And on exam, he's got a large palpable firm mass in the left testicle. He receives an ultrasound with a 6.5 centimeter hypoechoic lesion, increased flow, replacing most of the left testis. AFP is 2, which is within normal limits. HCG is 129. Rich, this guy walks into your clinic. How does that kind of first pass counseling, high level things that we want to kind of lock in here?
Yeah. So, I begin the conversation with my concerns that this could be a testicular germ cell tumor. We kind of go over next steps in management. We've already got the scrotal ultrasound. Markers are elevated, so this is highly consistent with a germ cell tumor. We usually start to counsel the patient on some of the survivorship options that we consider prior to orchiectomy, discuss any potential need for family planning, begin the process of counseling him on sperm banking, some of the risks of potentially losing a testicle in this situation, and then generally move forward with, complete staging in this situation, CT of the chest, abdomen, pelvis with contrast. And then we start to talk about orchiectomy in this situation.
Quick question. Are you getting baseline gonadal function labs these days in patients receiving prior to orchiectomy?
Yeah, great question. We are. We've worked very closely with our andrology team, and, I personally believe very strongly in trying to get a baseline prior to any intervention, just to allow us to understand the delta afterwards too. And not only from a research perspective, just from a peace of mind perspective for a lot of these guys that do have concerns afterwards. I think it's a lot easier to counsel them on the potential issues afterwards if there is some baseline hypogonadism or, any evidence of testicular failure. And, obviously we'll push a little harder for sperm banking if that's the situation. There are even situations where, if we're getting someone who's azoospermic on their preoperative semen analysis, that we start to talk about oncotesty as well at the time of orchiectomy, especially if the other testis is atrophic or there's any concern that this could be the only testicle that's providing any potential, fertility function.
Perfect. And then high level orchiectomy counseling, what does that look like?
Yeah. So, we go over the risks of the operation. Obviously, this is, an outpatient procedure. Go through generally some of the potentials for bruising, expected recovery time, always counsel the patient on whether or not they'd like to consider a testicular prosthesis at the time of the operation. I've also started to talk to people about the potential for hernia repair during the operation. We look back at some of our data pretty recently, and about 1/3 of patients had some type of either subclinical or, obvious clinical hernia found at the time of the operation. So in general, we'll talk to patients about the potential need for that during it as well. Other than that, we just go over scrotal support. Ice is your friend after this kind of thing. Some lifting restrictions for the next 4 to 6 weeks. And I do a lot of pre-counseling on potential pathology even before the operation, just because I want to kind of prep the patient for that phone call that they're ultimately going to get about a week or so afterwards, where we start to talk about the pathology. And, as much as the patient wants to go through some of the potential next steps, we sometimes do, but I generally let them kind of guide me in that situation. Some people just want to get through the procedure and figure out everything after that. Others want to know a lot more details on what's potentially next. So we'll talk about high level things related to, surveillance and potentially the need for chemotherapy. Some patients will come in with complete staging imaging already, others won't. So it's really setting the stage and doing a lot of education even before something happens, just to, have the patient feel as comfortable and as much knowledge as possible, so there's no, fear or concerns.
Totally. I mean, I couldn't agree more. The prosthetic conversation seems like one that sometimes gets missed in the community. Fertility counseling, historically it was the sun never sets on a testis mass. I think these days we recognize that you can get the requisite information, sperm banking, so forth, staging. Love that. And yeah, I think you kind of covered it perfectly. So we did all that, and this patient went on to receive an orchiectomy. And that indeed showed a 4.5 centimeter seminoma with some reedy testes invasion. His markers have normalized and his imaging is negative. Nabil, question for you. The stage 1 patients, this is actually something that came up in a recent email chain that I was on. Who's typically managing these at Indiana and Memorial? Is that going to be the urologist? Is it going to be the med-oncs, combo, patient preference? Tell us a little bit about that.
I think at our place, for the majority of patients, it's a sort of combo. Both urology and med-onc would see the patient. We would both counsel the patient, about the options for stage 1 disease, go through the pros and cons of each of those, and then decide on, what treatment approach the patient wants. For the vast majority of patients, for stage 1 seminoma and non-seminoma, honestly, we typically would recommend surveillance. And so usually either urology or med-onc would follow the patient with urology, but for the initial consultation, usually it's a combo with both urology and med-onc.
Rich, does that sound about right?
Yeah, that's very similar by us as well. A lot will have to do with just the flow of patient access to some degree. If the patient still has not had an orchiectomy, they'll see us primarily. If they have had a prior orchiectomy, they'll be offered either dual consultations or consultations with one or, either of us. We're very fortunate to have clinic with the two primary medical oncologists, Dr. Feldman, Dr. Funt, at MSK on the same day on Thursdays. So, we're frequently sending patients up and downstairs to each other just for, same day consultations. It's very much a team approach and a team effort. And we have pretty much aligned our surveillance standards and recommendations. All of our imaging and tumor marker checks are identical in the medical and surgical oncology space. And we have a very similar approach to favoring surveillance for, certainly everyone with seminoma outside of extenuating circumstances, and for, a decent amount of patients in the absence of any risk factors for non-sem.
And the other part of it too is, if there's an option for a clinical trial. So at some point we're enrolling on SWOG 1823 with microRNA 371 for stage 1 disease. So typically med-onc used to follow those patients here, but at the same time, it's just whatever the patient preference is going forward. But similar to what Rich is, the initial consult was dual essentially.
Yeah, I also feel quite lucky to have my med-onc partner in crime, Fred Millard, same day, and we try to see all patients, new diagnoses at the same time. Perfect. Yeah. Thanks for the shout out to the clinical trials 1823, AJCT 1531. Actually, there's an observation arm and an intervention arm. Great thing to think about. So my sense is sometimes in the community that the urologist may see themselves as a technician to do the orchiectomy and then pass them on to a med-onc. It'd be curious to see if that's indeed the case. It would also be interesting to see if the use of adjuvant therapy is higher in community practices versus places that are a little bit more familiar with patients with germ cell tumors. But I could agree more. We see some features here: the size, reedy testis invasion. He was a T2 tumor with lymphovascular invasion. Again, kind of nothing extenuating, nothing in terms of overall overwhelming patient anxiety, access to care. They're going to Peace Corps for a couple of years. Is it safe to say that a major take-home message here is, outside of anything beyond the typical, that surveillance is really going to be the preferred option for patients with the stage 1 seminoma?
I think so. From our perspective, I think surveillance is the correct approach here, unless, you worry about somebody who might not follow a surveillance schedule, or they might get lost to follow-up, or, there's other reasons where surveillance is not appropriate. But I would say for the vast majority of patients, surveillance is appropriate, even if they have some risk factors, like in this case, a bit of a larger tumor or possibly metastasis invasion. I still think surveillance is the appropriate approach.
I mean, I think the thing I always discuss with the patients is that adjuvant therapy in this situation does not change overall survival. And I think there are, in fact, some concerns about adjuvant carboplatin potentially lengthening the time to relapse if someone is going to relapse, and potentially resulting in some more difficult to manage relapses or more atypical relapses that may not necessarily just occur in the retroperitoneum. The Spanish study showed that, even with a risk-adapted approach, you're still going to be overtreating the vast majority of people and not really changing the absolute risk of relapse considerably to justify it. So definitely think surveillance, even with some of these factors, is still the right answer.
Yeah, I think the hope would be with more novel biomarkers like microRNA 371 or potentially circulating tumor DNA, that you can actually tease out this very small number of patients who are actually going to relapse on surveillance and actually treat patients with adjuvant therapy where it's appropriate, as opposed to just treat everybody with a very small percentage of patients who would end up relapsing.
So generally speaking, when you're having the conversation, making sure the patient's informed of all of their options. And Nabil, maybe obviously surveillance is surveillance, relapse risk, call it 6 to 25% based on risk factors. Generally speaking, it's going to be surveillance for all. But can you give us like a quick sense of what your adjuvant talk looks like?
If I'm gonna recommend adjuvant, you mean?
Well, more just when you're running through the options.
Yeah. So, we usually start our conversation by telling patients, you're almost surely going to be cured of this cancer. The chance that this cancer is going to shorten your longevity or affect your lifespan is very, very, very small. So no matter what option you choose, you're almost surely going to be cured of this cancer. The only question is how you're going to be cured. And then we go through the options, go through surveillance with the surveillance schedule, how often you're getting markers and scans and so on, and just hammering down the important information that, you need to show up for those surveillance blood tests, images, clinical exams. You really should be very compliant with those and avoid missing any of those, because what could be easily curable if you catch it on surveillance could become more difficult to cure if, you missed a couple of scans. And, typically go through percentages where, if you go on surveillance, your chance of relapse somewhere between 10 to 20%, depending on your risk factors and so on, but generally very low. And then we go through adjuvant therapies, and we typically would say this is not something we'd recommend, but it's nothing wrong to do them. It's part of the guidelines. It's, studies have shown benefit to those adjuvant therapies. And so go through single cycle of carboplatin or with radiotherapy. And then, the idea is you do carboplatin or radiotherapy, you're dropping your chance of recurrence substantially today. But we don't know what the long-term toxicity of that is. We don't know what the long-term toxicity of radiation today for somebody who's 23, who's going to live to, hopefully many more decades of life, whether that's going to cause secondary issues, secondary malignancies, and so on. And then same thing, we don't have survivorship studies looking at long-term carboplatin. I mean, single-dose carboplatin seems fairly minimal, but still it must have some effect as far as survivorship, and we don't know what the long-term effects of that single cycle are going to be.
Perfect. So this patient went on to a surveillance program. I think I'm hearing from the group that that's a consensus. Indeed had a recurrence. So completely staged at this time. Generally, they have a recurrence. I think we want to get comprehensive staging, CT scan, chest and pelvis markers. All of those are negative. What does this conversation look like? Maybe starting out with, here's your comprehensive set of options that are available.
So this looks to be, solitary recurrence. I'm assuming it's less than 2 centimeters based on the CN1 here. Inner aortic cable space, left-sided primary, so sort of well within reason for the primary landing zone here. I think we kind of give a very balanced discussion at MSK on this. We tend to highlight the traditional standards of, chemo and radiotherapy in this situation, talk about the emerging data with RPLND, obviously talk about the SEMS trial, the other phase 2 studies, as well as our own institutional experience, and kind of highlight the goal remaining, as Nabil said, that, you're still almost certainly going to be cured in this situation. The question is really how, and how do we get there? And, we do talk about some of the concerns, at this point, that you're talking about either, 3 cycles of BEP or 4 cycles of EP in this situation, which is far more toxic potentially than carboplatin, and just trying to, discuss with the patient what their long-term goals are, how risk averse they are, while also balancing the, lack of certainty with cure with surgery in this situation. We quote about 80% pre-op risk of long-term cure with a recurrence like this, but, I think some of the data are still developing. I do think that, some of the series that are only including up to 2 years may see some more recurrences long-term. And I think we try to be very fair about the potential benefits of RPLND in this situation, while also weighing the risks that you very well may need chemotherapy if you relapse again, and, thereby exposing yourself to the toxicities of both therapies.
I mean, very similar approach at Indiana. From our perspective, we review the scan with a patient. This is probably a case that will be discussed at tumor board. One thing that comes up is this a real recurrence, or is this, a reactive lymph node that's going to go away? Do we need a biopsy? That's something that comes up frequently. I think with this sort of pattern, this looks fairly consistent with a seminoma recurrence. The location, the appearance of the lymph node, all that, it seems to be consistent with a seminoma recurrence. So I don't necessarily feel like a biopsy is warranted, although we've seen cases where, you see lymph nodes like this show up and you operate on them and they're actually, M0, or there's no disease there. But that's the minority of cases. But so we counsel the patient, there's no need for a biopsy. This is likely a recurrence, obviously check markers. My guess is in this case is the ATG is still normal. Very interesting in those cases to, again, look at biomarkers like microRNA or ctDNA to assess if those are positive. It gives you more confidence that you're dealing with a recurrence. And then you go through the options, right? So you go through with the patient that historically the options were for something like this, radiotherapy. Or you could do chemotherapy for good risk disease, which would be 3 cycles of BEP or 4 cycles of EP. But then we go through the newer data with RPLND for stage 2 disease, going through the SEMS trial, the 2 European trials, and also institutional data showing about roughly an 80% relapse-free survival in this sort of setting, while avoiding all the long-term toxicity of chemotherapy and radiation. And, to be complete, we go through the SAC data as well with, single dose carboplatin followed by radiation. I personally do not recommend that regimen, but just so that the patients are fully informed, we go through all those options and then go through sort of what we would recommend. Our group at this point for recurrences like this is almost uniformly recommending RPLND for those patients. This, Rich can correct me, but this seems like should be, from a non-surgical eye, should be an relatively easy surgery, avoid long-term effects of chemotherapy, avoid long-term effects of radiation, and offer the patient a very high chance of cure. Again, same thing, you're probably going to cure this patient. Question is how, and we want to cure this patient with the least amount of long-term toxicity.
Yeah, I think Nabil touched on something that's worth reiterating, is that PN0 rate. And I think there's a lot of nuance to that. If there were absolutely nothing in the prior scans where this lymph node is now, I'd be a lot more concerned that this is a true recurrence. But if this was something that we do see very often, which are fluctuating lymph nodes, potentially reactivity. Seminoma is a highly inflammatory cancer. So if there were something there that deserved another short interval CT scan, we would definitely offer that as well, simply because, you certainly don't want to go in and find PN0 pathology, although obviously that's the best case scenario for the patient. It still gave them an operation that they may have been able to avoid with a repeat CT.
Totally. You look at the number of nodes. Does it look to be adherent to the vessels? Was it, de novo stage 2 versus relapse on stage 1? Short interval re-imaging, full templates. I think these are all kind of the things you have to look at as we learn more about this disease, and even patient selection for non-seminoma, quite frankly. These are critical and really need to happen in multi-D conferences, to really dig in and make sure that you're selecting out the patients that are going to benefit and those that are not similarly. So he went on to receive an operation, and sounds like that would be a reasonable consensus at Indiana Memorial. And on his final path, he had 1 out of 36 lymph nodes involved, seminoma, pure seminoma. The largest dimension was 2.2 centimeters. no extranodal extension. So his PN stage would be a pathological N2. All right, you see him in the office. He's, getting back to it. His ejaculation is intact. No ascites or any of that kind of stuff. Back to the, his school, etc. And he asks you, what do you think? Should I consider some post-operative chemotherapy or radiation or immunotherapy or anything? Typically, what are you guys going to advise in this context?
Yeah, so there's not a lot of long-term data, right, with RPLND. So like Rich said, we're still looking for long-term data on those studies. It'll be important because seminoma can relapse relatively later. But the data we have so far is without adjuvant therapy, you're looking at roughly an 80% relapse-free survival. My take on this is the whole purpose that you're doing surgery here is to avoid chemotherapy or radiation. So it doesn't make a whole lot of sense to do an RPLND and then, because of a positive lymph node, you knew there was going to be a positive lymph node, to then go ahead and give adjuvant therapy and expose the patient to that potentially long-term toxic chemotherapy. So our sort of protocol has been to observe those patients with surveillance. Of course, there are some exceptions. If somebody has an operation and they have very large, bulky lymph nodes, large number of lymph nodes, large in size, then potentially we could consider adjuvant. But for the vast majority of patients, we are observing with surveillance.
Couldn't agree more. I think microRNAs and circulating tumor DNA are going to be extremely exciting here. Extrapolating from the non-seminoma work that's been put out by several groups, including the group at Indiana, seems like in contemporary well-selected patients that the bulk of patients actually do quite well without adjuvant chemotherapy. And I think the guidelines kind of reflect that. And specifically for seminoma, I think what adjuvant chemotherapy even looks like is really the wild, wild west. Consensus on trying not to use it. You highlight contemporary imaging as critical. You don't want to have scans that are 3 months old when you take somebody for a primary RPLND. And I think these are, given that this is such a small sliver of the germ cell tumor pie, it is incredibly exciting, interesting, and, lots to come out. So, Rich, what do you think? Basically observation, is that going to be the punchline here?
Yeah, I think, in the absence of surprises, which is what Nabil alluded to, we tend to probably favor observation because of those exact reasons. Most patients went with the surgery to avoid chemotherapy. However, there are some situations, I think, especially where patients may have relapsed after a long period of surveillance already in clinical stage 1, that they may not want to go through this again. And they ultimately drive some of that conversation towards adjuvant therapy in that situation. We'll always have them meet with the medical oncologist to get kind of the most balanced view on things and just go through the logistics and the risks of what we would give in the situation, which would be EP times 2. But the logic does hold that most of these patients went with the surgery to try to avoid chemo. And in the absence of anything surprising, many do just prefer surveillance in that situation.
Fantastic. Well, let's move on to the next case. I think in many ways, patients with seminomas and non-seminomas may be ultimately kind of converging in terms of the way we manage them. So this is an interesting case of mine. A slightly older patient, 44-year-old. He had a right-sided testis mass, mixed non-seminoma germ cell tumor. Preoperative markers were notable for a slightly elevated AFP of 22. Post-orchiectomy, his markers normalized, and you can see his scans here with a few enlarged para-aortic lymph nodes. So again, it's a right-sided mass. We see these nodes to the left of the aorta. First pass thoughts here, guys. What comes next?
So I would dive a little deeper into the guy's history just to make sure that there's nothing to suggest an aberrant drainage in these situations. It's very reasonable to have a right-sided primary and end up having, para-aortic lymph nodes just based on what we know about predictability of lymphatic drainage. But we don't know everything about lymphatic drainage, I would say. So it does give a little bit of pause when things don't match perfectly, but this is still within reason. So if the patient hasn't had any prior inguinal surgery or anything like that, in this situation, from at least this image, it looks like there may be a couple of para-aortic lymph nodes here, maybe nothing bigger than about 2 centimeters. The timing and, the multiplicity give me a little bit of pause in this situation. I would certainly have this patient, see the medical oncologist. The presence of teratoma here also is another consideration, I would say. And with markers being normalized, you wouldn't want to potentially give this patient chemotherapy if there is teratoma only in the retroperitoneum. The chances of that are really only on the order of 10 to 20% in this situation, but it's certainly a consideration as well. But, I think this person has a lot of options. I think it would be reasonable to even pursue short interval imaging just to make sure there's nothing else that's going to pop up. But, primary bilateral nerve sparing RPLND in this situation would be, I think, very reasonable, but as would some very short interval surveillance or even treatment with chemo, I think.
What do you think, Nabil?
Yeah, the pattern of spread is a bit unusual, but I mean, not impossible, right? So, this is mostly a non-teratomatous tumor, but it does have 5% teratoma, which indicates he probably has a big chance of having some teratoma in those lymph nodes as well. I do think RPLND is a reasonable option here. So I think it's a discussion with the patient as far as the pros and cons, both approaches. But yeah, I agree with Rich. I think RPLND is a reasonable option here.
Yeah, absolutely. And, when you look at these this imaging in this cut, the cranial-most lymph node kind of has a rounded, more typical appearance. The caudal-most lymph node has a more rounded-ish typical appearance. That middle one, almost, I could convince myself that it's inflammatory, no recent diverticulitis or anything like that. So in terms of next steps, we had a conversation with the patient, of course, and he elected for short interval imaging in 8 weeks, and this is totally stable.
Very common situation.
Yeah, and again, I mean, if we kind of, you can either pull the trigger on surgery, you can do chemo, you could do short interval imaging. I suppose one could make an argument to try to biopsy one of these fellows. I think these are all, we're hearing them, they're all quite reasonable. So, and obviously I know the patient. He was starting to develop some anxiety about the whole situation and kind of wanted to have some clarity. We've kind of run through the options, no real change here. Clearly, continued surveillance might be an option. And he went on to receive surgery.
I would say chemo would be the only thing I wouldn't do based on a repeat imaging with no change. So at this point, I would either continue watching or do surgery, but I would not do chemo. So
yeah, and if you're going to do surgery, Rich, what does that surgery look like?
Given the slightly atypical distribution of the nodes with a right-sided primary, I would definitely do a bilateral. And if indicated, the patient desired for either fertility or sexual function, nerve-sparing procedure, but definitely a bilateral procedure in this situation.
Perfect. So that's exactly what we did. He went on to receive his operation. Pretty interesting pathology. I think actually a few of those were likely reactive. Ultimately, there were small foci of seminoma. I think it was a reasonable lymphadenectomy. And I think we kind of alluded to this in our previous conversation, but if this guy walks in, he's meeting the multi-D clinic, what does the kind of post-surgery counseling look like?
So again, I think he has small foci of seminoma. This is a bit of an easier case where there's small foci of disease, both sides, but this is somebody we would certainly recommend surveillance for. And again, probably looking at a decent chance of cure with surgery alone.
Okay, so if we move into some slightly more, and again, this is just that same data. I love the fact that the guidelines are being updated. It used to be almost like reflexive chemotherapy for N2, N3 disease. Seems to be a little bit of a shift, is my sense. So the next case, interesting case, 17-year-old young man, fairly substantial developmental delay, autism. And I'd love to hear comments on this. I think sometimes there's data suggesting it. Sometimes in patients that have some developmental delay, we see more advanced stages or they're slightly older and being examined by their parents. He's found to have a large heterogeneous left-sided mass. Tumor markers are substantially elevated, and his imaging is notable for fairly diffuse disease. On exam, very pleasant young kid, palpable mass, massive left hemiscrotum, no lower extremity edema, and we can actually take a quick peek at his imaging. So he's got fairly extensive pulmonary metastases, also fairly substantial retroperitoneal disease, large scrotal primary still in place. Let's just run through a little bit of, what are you all thinking? Practical considerations. What comes next for this gentleman?
I don't think you need a biopsy. I think with the AFP of 3,000, HCG of 250K or something around that range, with testis mass and this pattern of disease, what you're dealing with. This is clearly a non-seminoma with probably a component of choreo or embryonal with this high HCG and lung and liver, so visceral predominant metastasis. The question is whether you should do an orchiectomy first and then start chemo, or start chemo and then do an orchiectomy, later on after finishing your 4 cycles or between cycle 1 and cycle 2. It's not as clear-cut. If the patient is stable and they are feeling mostly fine, they're not in respiratory distress, they're not in pain and so on, I think doing an orchiectomy first and then starting chemo a few days later, 3-4 days later, is perfectly reasonable. But I've had patients who showed up to my clinic with hemoptysis, shortness of breath, they're on oxygen, big testis mass like this. For those patients, we admit them the same day, start cycle 1 or what we call cycle 0 of chemotherapy actually, and then just do an orchiectomy between cycle 1 and cycle 2, sort of a delayed orchiectomy. As far as brain imaging, I don't think there's clear consensus on this. My impression is somebody who has visceral predominant metastasis like this with lung and liver mets and also with a very high ATG, they have a higher likelihood of having some brain metastases, so I would get brain imaging. We actually put out a prediction model for brain mets that is in press right now, looking at different clinical criteria, and this patient satisfies a lot of those criteria. So I think the chance of this patient having brain mets is quite high, but it won't impact what we would do. We were not going to delay chemo for brain imaging or for potentially like brain radiation or whatever. We would still start chemotherapy. Sperm banking is tricky. If we can get it done quickly, then yes, we would do it. But again, in some patients who are in more respiratory distress or on oxygen and so on, then starting chemo is more of an urgency.
I would say that for this patient, in counseling them and the parents, that I would tell them that doing an orchiectomy at this point can only hurt them. I worry very much about any potential bleed, surgical site complication, anything at all that could potentially, delay chemotherapy and cause this to become a completely unmanageable situation. So although it would be reasonable to do it to truly confirm things and to begin any sort of tissue genomic studies that maybe, indicated warranted or of interest, I would say that the diagnosis is quite clear. And we've generally done orchiectomies in a delayed fashion after chemotherapy, even at the time of post-chemo RPLND. For patients who have a considerable amount of lung disease and maybe more so than retroperitoneal disease, I've done orchiectomies with our thoracic surgery colleagues when they've done wedge resections or VATS. The risk of any residual cancer being in that testis after chemotherapy is probably about 5%. This patient has a decent likelihood of having some teratoma there, but there's really no urgency to doing the ORC, I would say, in these situations. And the last thing I would want is for someone to develop a brain bleed or considerable lung compromise because of a surgical complication, especially in someone who's developmentally delayed that may have some issues even with an inguinal orchiectomy. The other consideration too is the feasibility of it. We've seen plenty of situations where the cord is just encased in cancer. And, I've palpated or seen it on imaging that there's just quite frankly no way I'm not going to be just cutting through tumor when doing this. And, with chemo, you can downstage things pretty considerably and get a good margin and be able to do a much safer operation without the risk of tumor spillage. So that's another consideration, I would say. I actually didn't catch what the inguinal region looked like on the imaging in this one.
It's a perfect point, and we've actually discussed it on a previous podcast that you got to look at those coronals and make sure there's not a big kielbasa sausage heading up from the testicle up into the retroperitoneum where you're going to have a positive margin. All great points, and we can even talk about the nuances of this. If it's like a 20 centimeter mass and they're severely bothered by it, they're hardly ambulatory. But yeah, he was in lost some weight, reasonable shape. He was actually seen at our children's hospital initially. They got a percutaneous biopsy and then sent him our way. And Nabil, just in these guys with fairly extensive lung metastases, what's the preferred regimen going to be at Indiana?
So he has poor risk disease. So those patients should be treated with 4 cycles of triple drug therapy, either BEP or VIP. For somebody who has extensive lung metastases like this, we would favor VIP, avoid the bleomycin, and plan for 4 cycles. His, chance of cure with first-line therapy with this regimen for all poor risk patients is around 60%. This patient, his prognosis is actually worse than that. He's got 2 poor risk criteria. So he's got ACG more than 50,000 and he's got liver mets, so non-pulmonary visceral mets. And, we published that if you have 2 or more poor risk criteria, your chance of cure is actually closer to 20 to 30% with frontline therapy. So, but still not 0. And I, still think 4 cycles of triple drug therapy is the right approach here. In some patients who are actively bleeding or who have massive lung metastases, we actually start with what we call cycle 0 and not cycle 1, where we would do just 2 or 3 days of EP only, so cisplatin etoposide, just for 2 or 3 days. And a large proportion of those patients, they would have worsening hemoptysis and bleeding with that cycle. Some patients need more respiratory support. Some patients need to go on the ventilator for a short period of time. And that would be just to get the disease under some control. And then after they invariably those patients recover, then 3 weeks later you start your actual first cycle, and you would do 4 cycles of triple drug therapy starting then.
You'll see that he indeed got a percutaneous biopsy, mixed non-seminoma germ cell tumor. He received poor risk directed chemotherapy, Nabil, as you alluded to. During the chemotherapy, he had an appropriate marker decline. And you can see over the several next coming months that his HCG slowly kind of worked its way down. What do you think here? Is this comforting? Is this concerning? Is this too early to call it?
I think it's too early to call. So a lot of times what we see is the HCG does a big drop initially with chemotherapy, but then plateaus, similar to what we're seeing here. And then the HCG declines fairly slowly. Actually, the big chunk of patients with very high HCGs that start with HCG more than 50,000, they sort of do not normalize their HCG after 4 cycles of chemo. They still are dropping. It's just they don't normalize right after finishing chemo. So you just have to watch their HCG. Our practice is we follow their HCG on a either weekly or bi-weekly basis until the HCG either goes down to normal, and then we start discussing, whether we need to resect residual disease for teratoma and so on, or until the HCG starts rising. And if that's the case, then we start discussing salvage therapy.
What do you think, Rich? That sound about right? You jumping in on this guy right now, or are you going to let the chips settle a little bit?
No, I would slow play this very much because he's at very high risk of needing salvage chemotherapy. Dr. Scheinfeld has imparted his infinite wisdom on me that the HCG is really the thing that scares all of us, I think. You could see some AFP trapping in teratoma, and you don't get as concerned with kind of a smoldering AFP as you do with an HCG. But doing an operation, I think, in this situation puts the patient at risk based on the preoperative or the pre-chemo imaging, at least, probably of losing a renal unit or something that's really going to hurt his chances at tolerating either TIP or high-dose chemotherapy after this. So, we'd be very, very cautious not to, pull the trigger too soon on an operation, because this patient, unfortunately, is almost destined to need salvage chemotherapy.
Yeah, I couldn't agree more. And, on the one hand, you don't want to pull the trigger and say that this patient currently with a low, non-rising, declining HCG has unequivocal active germ cell tumor. I think there's a nice paper from Indiana of these kind of suprachoriocarcinoma syndrome patients that can have a long tail that never gets to normal. On the one hand, on the other hand, spot on. You don't want to pull the trigger and, do this big operation, potentially lose a kidney, and now you've precluded next step. I think we've kind of talked about, we keep a close eye on this guy. Right now with his markers declining, I think the consensus would probably be that just keep an eye on things. Does that sound okay?
We have considered doing an ORC in situations like this, where with a smoldering HCG, just on the off chance that there is residual kind of, viable cancer in the primary tumor that would otherwise normalize afterwards. I do have maybe 2 or 3 cases I can remember that has actually brought the HCG back down. The blood-brain barriers, or the blood-testis barrier, I should say, is a real thing. So that could prevent the patient from needing to go on to, getting salvage chemotherapy in some situations. But that's a bit of a Hail Mary in someone who hasn't already had an orchiectomy. I even scan, get an ultrasound of the other testis to make sure that there's no, reason why the patient can have a second primary tumor. Re-imaging the brain, of course, I think is an imperative here, especially before an operation. And, getting your ducks in a row, if you do ultimately wait this out and things continue to normalize or really plateau over a long period of time, getting your liver surgeon involved, getting your vascular surgeon involved, figuring out the sequence, whether you're going to do things together or in a staged fashion for any residual disease. But, these are real serious situations, I would say.
Yeah, I agree. I think this is the nice window for orchiectomy. I think orchiectomy in this setting is appropriate to evaluate because, testis is a sanctuary site, so you might still have active disease there, and you don't want it to just make things a bit more unclear moving forward. But I certainly would not consider any additional surgeries like RPL&D or liver resection at this point. If the patient is not cured with chemotherapy, and RPL&D or liver resection is not going to cure them, it might take care of any residual teratoma, but that's less of a problem right now. So
I think we're all tracking 100%. And if we'll see that despite the initial marker decline, that his markers started going up. You can see here just in a few weeks, non-trivial. And, this is one that I struggle with. I didn't really struggle with slow playing it. And I'm glad I didn't jump in and do anything. I think most people at higher volume centers wouldn't have done that. What about now? What comes next? So his HCGs rose, I would say, somewhat abruptly. And then, during this 2-week period, and then again, another 10 points or so.
Not with an HCG of 187, and it's a really long shot. But first thing is I would call the patient to make sure they don't use marijuana, because it can cause false elevation HCGs. And I've had patients, with HCGs as high as 50 or 60 where it's because of marijuana use, and they stop using marijuana and goes back down to normal. So, but this pattern, this disease with an HCG of 187, I think this is real, but worth checking that. But at this point, I think you are starting to see a clear and unequivocal evidence that you have disease progression. I would probably get one more HCG just to make sure that you have, 2 or 3 values that are consistent with a rise. Not that it makes any difference, but I think getting imaging is important. So I would image the chest, abdomen, pelvis. A lot of times what we see is the disease systemically is still stable or even still shrinking while the HCG is rising. It's important to get a brain MRI in this setting to check and see whether there is solitary progressive disease in the brain, which is causing the HCG rise, and also get a testis ultrasound, rule out a second primary. But for the vast majority of those patients, it's going to be an HCG rising. His systemic imaging is going to show either stable or still shrinking disease. And then brain imaging may or may not show evidence of disease. And so you started the conversation about salvage chemotherapy in this setting.
Yeah, absolutely. And, I think the previous slide, we talked about how critical it is, particularly in these cases, to get that brain imaging, the ultrasound. You don't want to miss something relatively silly. And he actually, he had a fairly substantial primary in place. And as we were getting our ducks in the row evaluation for high-dose chemotherapy with stem cell transplant, we actually did an orchiectomy. His HCG dropped to 5. And again, kind of, I think, somewhat responsibly slow played it, and shortly thereafter is 68. So, it would have been an awesome story for him to potentially avoid it if the testicle was the only site here, but that didn't seem to be the case. And I want to make sure we get to the last case here and be respectful of your time. So now sounds like high-dose chemotherapy, stem cell transplant.
So, it's a conversation about standard dose versus high-dose chemotherapy in the salvage setting. We don't have level 1 data. The approaches is either standard dose therapy with TIP as an option, VEIP or vinblastine iphosphite cisplatin as an option, or high-dose chemotherapy with transplant. The Tiger trial, which has finished accrual, Darren Feldman is the PI, enrolled patients similar to this as initial salvage, comparing randomizing to TIP versus TICE, which is the Memorial High-Dose Chemotherapy Regimen. So we'll see what the results of that study show. But there's very solid retrospective data. There's data from Europe with over 1,500 patients showing that high-dose chemotherapy is superior to conventional dose therapy as far as progression-free survival and overall survival across risk categories. So specifically with a patient like this with multiple poor risk features, we absolutely would favor high-dose chemotherapy in this setting. This patient technically is not platinum refractory, so he progressed 3-4 months after finishing frontline therapy. So if we were seeing him, we would treat him with a single cycle of standard dose therapy. At our place, it would be VEIP, and get him ready for high-dose chemotherapy and transplant with 2 tandem cycles. And for this sort of situation, we would quote the patient roughly around a 40% chance of cure out.
Okay, so he got his chemotherapy. We can see his post-chemotherapy imaging here. So good response in the lungs, nothing greater than about 0.8 millimeters. And you can see it seems to be kind of skipping, but the tremendous radiographic response. His markers have come down to normal at this point. It's all periodic distribution. And I think the standard here would be, particularly after salvage chemotherapy, to do an RPLND.
Yeah.
Okay. Well, so he got his RPLND with teratoma only. He's about a year and a half out, no evidence of disease, and really, really wonderful young kid. Happy for him and his family. They had a busy year. All right. So maybe one last one that we could run through. This is a 21-year-old who had left scrotal swelling for 4 months while he was a resident of Mexico. And ultrasound per report showed a heterogeneous mass, very limited medical records, a inguinal orchiectomy, identified a primary teratoma with extensive secondary somatic type malignancy composed of adenocarcinoma, rhabdochondrosarcoma. He received systemic therapy about 2 years after all of this started. His past surgical history was notable for an orchiectomy, a stent on the left-hand side, an IVC filter. He had no other substantial medical history. He was a Jehovah's Witness and came in to us with back pain and early satiety. On exam, he had a protuberant fixed abdomen, empty left hemiscrotum, nothing else kind of remarkable. And if we take a look at his imaging and markers, his markers had all normalized. His counts were all completely normal. We talked about sperm banking. Regrettably, he couldn't afford it, which is a whole nother topic of conversation. And here's his scans when he comes in. So we can see a relatively large mass displacing most of the viscera down to the left lower quadrant. If we look at the coronals in the next slide, here's a screenshot and then a video. Again, fairly substantial mass, significant hydronephrosis that comes out, crossing the midline, IVC filter in place. What comes next for this fellow?
So you said this was 2 years after he finished?
Yep, this is 2 years out. Markers normal. No real prospects of getting any records from his initial treating institution.
So no idea what this looked like after chemo and relative to now, I guess.
This is it. This is one of the, well, these are the patients we see.
Yeah, no, I'm just trying to touch all the bases here. You know, Jehovah's Witness, stent in place, filter in place. This is all of it. You know, obviously the concern here is for, depending on the timing, a late relapse. He had a lot of really concerning features to begin with, including the, secondary somatic type malignancy. With markers normal, I think you have to have a very serious conversation with the patient and with any other, of the surgical services that you may or may not want to involve in this situation about the resectability, because it's going to be very difficult to figure out exactly what this is. You can certainly consider a biopsy, but given the size of this, the, cystic kind of very heterogeneous appearance of this, I don't think you could be reassured if you're only getting a teratoma type biopsy result or anything like that. There's no way you're going to figure out exactly what this entire mass is with any sort of biopsy. So, I think you're very obligated in this situation to load the boat and consider doing a resection.
I did list out some considerations. Here's his lung, and this is actually worth taking a look at. This is his chest CT. I'd be curious in your thoughts when you have patients that have presumed extensive retroperitoneal teratoma and also extensive thoracic teratoma. How do you think about that?
Yeah, I mean, so this is 2+ years post chemo. His ORC obviously had transformed teratoma. I think this is a surgical disease. I don't think further chemo is going to help this patient. It always shocks me when I go to Clint Carey and Tim Masterson at our place and tell them there's no way you can possibly operate on this, right? And they're like, oh yeah, we can do this, no problem. So it's huge, but I think it's doable. And from what I've heard from our urologists is sometimes teratoma, it's not as tucked to adjacent structures, but again, this has, transformed elements as well. So I don't think chemotherapy has a role here, quite honestly. I think surgery is the way to go. Question is whether you would do the abdomen alone or whether there's any room to do the abdomen plus a single side of the chest. The abdomen was a lot here. Honestly, it's more of a surgical question. I would consult with our urologist at tumor board and see what their thoughts are. But if this was a smaller retroperitoneal lymph node, the discussion would be, do we do the retroperitoneum and one side of the chest and then leave the other side to another operation?
Yeah, if we go to the next slide, of course we run through these in our tumor board, talk about all the possibilities of second-line chemo. I mean, the resectability question, couldn't agree more. We got one shot, that the Jehovah's Witness element of it, that really does up the ante quite a bit. Clinical trials, brain imaging, I think there's plenty of things to consider. And ultimately, if we move on to the next slide, in addition to the kind of oncologic considerations, there's the surgical considerations. What do you think, Rich? Does this sound about like the things that you're thinking of and considering here when you're having your conversation?
Yeah, I think you have to explore everything in these situations, given the potential for massive blood loss in a situation like this. We even involve our patient rep and sometimes even legal in these situations, just given the potential for really seriously poor outcomes, because you want to make absolutely certain with the patient and his family what the directives are and make sure there's absolutely no ambiguity there, and to try to use every available adjunctive component of what you can. Auto transfusion, as long as this isn't truly rapidly explosive, if the patient is willing to go through that and accept that, that'd be very helpful. I think any of this other stuff, we have used the cell saver in these situations. Obviously, there's a theoretical risk that in a cancer operation, it could lead to problems with that. But I think some of the filters on these devices may help. But none of this stuff can be considered in a silo or in a black and white situation. It's all balancing risks and benefits. And, if the alternative is death, I think you have to accept, cell saver blood in this situation. I think the point about overall resectability is very important, though, because what we've typically done is to actually approach the more difficult of the resections first, because if that's not feasible, then there's very little benefit in putting the patient through any of the other procedures. So we've had some of these situations of massive teratoma, in the neck and the chest and the lung and the groin and the pelvis, et cetera. And some of these patients have undergone 5-6 operations in kind of reverse sequence from most difficult to least, or presumed most difficult to least. So I think that's an important thing to kind of discuss with the patient as well, that you do have to tackle the toughest thing first, because otherwise there's, you're putting someone through something that they're not going to benefit from.
Absolutely. Yeah. I mean, I don't think many people that take care of a substantial number of germ cell tumor patients throw around unresectable loosely. This is kind of more in surgical land. To get through this safely without something catastrophic like an on-table death is not a foregone conclusion. Planned nephrectomy, I would say that's likely going to happen. One of a paper I've come across actually involves preoperative aortic endovascular grafting, with the idea being that you kind of have a little bit of some liberty, around the aorta. God forbid you had an aortotomy. That could help out with some of the blood loss. This is totally from Dr. Scheinfeld, getting those filters out. IVC filters, you don't want those tines that penetrate through the IVC wall getting caught on a lap. Approach, what do you think, Rich? Midline chevron?
I think it depends on how high up you need to go, and if you do need to go into the retropleural space, or what you need to do with the liver. The imaging didn't show up all that well, so I didn't see if there was anything residual in the liver or retropleural area. But I think if you're going to tackle anything like that, a chevron will probably help. Otherwise, the midline is a remarkably good incision for most things. So I think it would be reasonable there. So it all depends on what you're planning on doing. If you need to get into the pelvis, chevron is sometimes a little more difficult based on the patient's body habitus, but even in that situation, it should be okay. And then I think you have to consent the patient for pretty much everything in this situation. Have your vascular team on board. If you're at a center that can put someone on bypass, I think it's very, reasonable to have someone available and on standby in that situation, depending on how much work you're going to need to do. If the cava is completely, obliterated and has been for a long time, looking at the potential for any of the collateralization, one of the things you can look at is the abdominal wall. If you see very thick vessels there, it's kind of an indication that there's probably good collaterals, and you can consider completely ligating the cava in those situations. And then, the colon is certainly going to be threatened too, depending on how stuck the mesentery is. If you're able to identify the IMA, what type of, additional mesenteric resection you'll need to do. So, having colorectal available in this situation too. You really need to load the boat in these situations, I would say.
Totally. This is not about, anybody's machismo or bravado. Just a couple of shots here, large protuberant mass. And, as you'd expect, that sigmoid colonic mesentery is completely split over the mass. there's the likelihood of maintaining that paper-thin mesentery on the marginal artery is very, very low. You can see all the small bowel contents just kind of tucked away in the right lower quadrant. If we go on the next slide, it was indeed a long day at the office. Here's just a side view. But we were able to kind of safely get through the operation and get things cleared out. He did require a partial colectomy, nephrectomy, and he actually had a couple of mesenteric nodules, which we don't see terribly often. And then the final path showed teratoma only, and he's NED 2 years out.
Nicely done.
It was, it was good to get through that one. His nadir hemoglobin, in full disclosure, was 6.8. It was stressful, but thankfully that's where he nadired and then settled out. And I guess, the intent of selecting these cases was really to highlight the opportunities to improve upon, perfect germ cell tumor management from the earliest disease states into the more complicated areas. And, to me, Rich and Nabil, you all in your institutions embody this type of careful, multidisciplinary approach to these patients. So I cannot thank you enough for sharing your wisdom and your experience with us. Thanks to the listenership. Appreciate it.
Great cases. Thanks very much.
Thanks very much for the invite, Aditya. This was fun.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.